Good morning, everybody, and welcome to this webinar on risk and liability. We will just let the attendees join. We've got nearly 600 people registered, and at the moment we're at around 250 and climbing in terms of attendees. So we'll just give everyone another 30 seconds, and then we'll kick off. So I'm going to start today by really just setting the scene. We are in uncharted territory, and I think we are at the edge of a precipice, which was one of the phrases that our panelists used when we were doing our rehearsal for this. We're staring at, from a liability perspective, claims of around estimated £120 billion at the moment, and the insurance world is looking at their solvency margins. And I think also looking at the broader economy. Today, we're going to focus very much on health and social care. And it's partly the insurance component, but it's also really what it means for operators, what it means from a CQC risk perspective. Will you be deemed to have been safe and well led in retrospect? What will the coroners be saying about deaths in your homes? How have you managed PPE? Given that I understand from Mark Adams, there have been 21 changes in the advice that people have been given. And actually, is the advice relevant to you, given that much of it is relevant to acute hospitals or to care homes, and what happens if you don't actually operate either of those? I think if you look at what's happening in the press, we're already starting to see things escalate. Citizens' advice have effectively advice on taking legal action if you have problems with adult social care. But you can see in Scotland that the Care Inspectorate, which is the CQC equivalent, is already ramping up its position there with a legal bid actually to remove HC1 as the owner of an infection-hit Skye care home, and the watchdog starting legal action there covered separately. So if you take all these together, UK carers losing their jobs, looking at legal action, abandoned care homes warning of action against councils, there is a general escalation in terms of where regulators, where providers, where commissioners and where funders are. So if one is looking at the market today, one has to have a mind to what is going to happen over the next few months, but also when people start to look at what's happened during coronavirus retrospectively and judging people on their actions today. So I just thought I'd also go through some of the key questions we had from attendees, because I think this helps set the scene. And I've put them into three categories: insurance, liability, and risk. The insurance questions were around how insurers are going to prepare with the public liability and employer liability claims that they're facing, and what kind of situations might lead to successful claims. And I think a more interesting one is what changes in insurance policies will we see following COVID-19? What sort of cover will be available? How will people try and restrict what you can purchase in the insurance market? On liability, what liabilities the government have due to the lack of testing in care homes, and of staff and residents. And I think this is particularly pertinent given the submissions that were made yesterday to the Select Committee by the sector, which many of you may have seen. Will parties take class actions? What approach will be taken to data protection? What liability do surveyors have if they're trying to inspect care homes for valuation purposes? The banks won't lend without a valuation. And how can providers protect themselves from future PPI claims from employees? So there's a whole basket of different questions there around liability. And then around risk, what risk sharing approaches could providers and commissioners take to mitigate and manage COVID risks? If staff develop coronavirus, where does employer liability lie? Can we be held accountable if you followed all the guidelines and responded accordingly, given what I just said earlier about the number of conflicting pieces of advice that people have had, and what are the key challenges to keeping people safe. So I think if you look at it, there is a huge amount of advice out there, but I think the litmus test is, what advice do you take? And secondly, how do you implement it from a practical perspective? So during this webinar, we're going to use Slido again. And the reason we use this is twofold. One is because there are live polls, and two is for the Q&A, there's an opportunity for you to vote up the questions that you think are most relevant. So if I could just encourage you to go to Slido in your browser, you just go to slido.com, and you can do this on a mobile phone, on a tablet, on another screen, on your computer. And there is an event code, which is R&L. That's spelt out R-A-N-D-L. And you can see there's a little event code box with a hashtag. If you just put R and L in there, then you should get onto a page with the poll. So when we have the Q&A, just type your question in. You can put your name in, or you can remain anonymous, submit the question, and then you can see there is an opportunity to upvote those questions in due course. So what I'm going to do now is just share the poll screen. So hopefully you can see that. So 17 of you, 22 of you, 27 of you managed to get in. And look, I mean, this is, I think, a highly relevant question. What is your biggest concern today? Is it the risk of what you're missing, what you don't know? There's unquantified risks that may not even be apparent at the moment. Is it liability for service users or patients that are in your services that may be dying from coronavirus? Have you done the right thing to protect them and yourselves? Is it employee liability for mental health, for lack of PPE, for lack of testing? Or is it having the right levels of insurance coverage? Because as you'll hear from Philip Dern from Marsh, there have been some significant changes in the sort of coverage that's available and the cost of that coverage. So we'll let that carry on in the background. We're at 111 respondees so far, so that's great. So hopefully that will keep going. And if I go back to the slides and just introduce our panelists. I'm absolutely delighted we've got such a fantastic lineup of panelists today. And what we've tried to do is get a balance between providers who are very much at the coalface, trying to work out where risk and liability is and what actions they need to do. Lawyers in the form of DAC Beachcroft, and insurers in the form of Marsh. So Mark Adams, CEO of Community Integrated Care, will be up first, followed by Sarah Livingston, who's General Counsel for Elysium, which is an adult specialist care provider. So slightly different from care homes. And then Ruth Winterbourne, who's a partner at DAC with a focus on claims in health and social care. So coming very much from that liability perspective. And then Jill Wetherill, who is more of a regulatory lawyer. And finally, last but by no means least, Philip Dern, who's the healthcare practice leader at Marsh, who's very much been on the forefront of looking at the insurance cover that's available and how that's changing in the market. So on that, I will hand over to Mark to introduce us to Community Integrated Care and take us through his perspectives. Mark's also a non-executive at National Care Forum, so I think is incredibly well placed to understand exactly where the sector is and what the issues are. So Mark, over to you.
Thank you, Henry, and good morning, everybody. I mean, first of all, Community Integrated Care, for those of you who haven't come across the charity, are one of the largest charities generally in the top 40 in the UK. And in addition, we're probably in the top 5 in terms of social care. We've got a team of 6,000, an organisation with a turnover of about 140 million. 98, 99% of that is public sector funded. We have about 4,500 vulnerable people that we support through about 450 locations. Prior to the COVID crisis, as many of you know, social care was feeling the strain anyway through a long period of austerity. And as an organisation, we were surviving by our supported living sector, making about a 2 million a year surplus, which effectively subsidised our older people services that focus mainly on supporting over 1,000 people living with dementia, which was generally making about a 2 million loss, which is due to the very low levels of funding if you don't have a very high proportion of self-paying clients who balance the books with what local authorities can afford to pay. The charity's been around for a long time. It has been doing a lot of innovative work around technology and trying to think about what the new future for social care might look like. But clearly, a year where we had exciting plans has suddenly become a year where we're just focusing on COVID. If we can go on to the next slide. Basically, when we started seeing what was happening in China, and then scarily in places like Washington in America, where COVID got into an older person's home and 17 people died in a week. We then saw what happened in Spain and Italy, where it appeared as though almost half the deaths were occurring from residential care homes. And we obviously saw in Spain that tragedy where one of the care homes, the staff literally ran away because of the fear of fighting COVID face on. And you could see this heading towards the UK. There was no reason to expect we were going to get any different experience to any other part of the world. And so as an organisation, at the end of February, we set up effectively a war room where we took some of our top directors and managers and just literally said, concentrate on supply lines, concentrate on comms, let's make sure that we're doing absolutely everything we can to fight what's ahead. We have always regarded that social care would probably be the last to be supported through the system. And we weren't at all surprised to see the focus on the NHS and ICU capacity, ventilators, and then Nightingale hospitals. And we've certainly had to source 92% of the PPE ourselves. The system has been appalling in that regard. We shut down all of our 450 services in terms of visitors at the very beginning of March. We anticipated some tough decisions along things like end-of-life visits. So we established a board ethics committee to really try and share the burden of tough decisions. And we then set about reporting daily with a series of dashboards that really would just capture the trends that we went on to experience. One of the things in social care that is appalling, apart from the fact that the majority of people live on minimum wage, and if you're on sort of under £8 an hour and you don't get sick pay in your contract, the idea of saying to the 2 million people in social care, please go in, fight COVID, and by the way, if you get sick, you're going to get £94 a week as statutory sick pay, didn't feel right. So we put in emergency measures for our staff to support them through both sick pay and a slight increase in salary. And we moved all of the operational support teams to home working. And we've obviously seen some amazing results driven by necessity. The time to onboard new team members massively truncated, and digital learning really breaking all expectations in terms of effectiveness. But I think in terms of risk mitigation, we felt that communication was going to be key. So daily cascade calls across the organisation, creating a dedicated website and 24/7 call centre. So anyone with any question about what PPE should they wear, what's the latest guidance, any concerns, any fears of an outbreak. And then we also set up regular family webinars so that anyone that wasn't able to go in and see their loved ones at least could see the eyes of COVID and the process of handling the pandemic through the charity's eyes, and they could ask any questions they liked. And we tried to take a proactive stance when it came to the media to shine a light on the government's deficiencies in what they've done. So if we go on to the next slide, we're basically in a situation where, because we acted early, we haven't been as badly hit as many of the large care home groups. So far we've had 172 people infected with COVID. We've had 4 people that have recovered. And sadly, we've lost 46 people of those that we've supported, 11 from a supported living environment, and the balance in our sort of nursing homes. To give an indication of the costs of handling this, we've so far incurred direct costs of £2.5 million. We've got a monthly run rate of about £1 million. And even though the government promised putting in 3.2 billion to the front line of fighting and supporting adult social care in the COVID crisis, 70% of all local authorities aren't even talking to us. As Henry mentioned, it doesn't help when you're trying to run a campaign where almost on a weekly basis, or sometimes twice weekly, you're getting changes in direction of what PPE staff should be wearing in different instances. The CQC has asked for consolidated weekly reporting, which again we've strongly said we don't support, because as they cluster so many of our services, it doesn't tell them anything anyway. So if we're going to be reporting on 26 different services under one cluster, it doesn't give them that forensic detail, and the local authorities still want virtually daily reporting on every one of our 450 services. Testing has been diabolical. We've at the moment only had, out of our 5,000 frontline care workers, about 250 tested, and that has massively geared up in the last 7 to 10 days. As early as March, or mid-March, we weren't getting tested for residents or for staff who presented with COVID symptoms, and we were seeing at that time hospitals trying to transfer COVID patients into care homes, and we were having to sort of resist at all costs. And knowing from the sector, I was hearing homes that were basically being threatened that if they didn't take in COVID patients, then the local authorities and the system would look dimly on them as a client in the future. We feel very much that the sector has been left alone. So the ring of steel that we hear politicians talking about, I don't think makes any sense at all. And obviously, as we come out of the first wave, fully anticipating a second wave, the joys of seeing the PPI claims that we've seen for years transfer into PPE claims is going to be another burden, where you've got a very complicated underfunded day job. You've got the aftermath of supporting families and staff who are going to have post-traumatic stress syndrome for what they've seen and had to deal with. And then you're going to be managing a claims environment that's going to be highly unhelpful. So as an organisation, we've basically said our paperwork's got to be pristine. We've got to keep our insurers involved, up to date on a daily, weekly, if not daily basis. We've got to keep families involved. Where we've lost somebody, let's do closure sessions with the family, bereavement counselling, and at least try and get the families on side that we've done everything we feasibly could. But I think we're anticipating a very tough year ahead. Thanks, Henry.
Thank you very much indeed for that, Mark. That's a very helpful introduction. I think just to sort of pull out a couple of themes there, I think the first was around costs, whereas you said you've seen £1 million a month increase in your cost base. But I think the challenge, which has been a pretty consistent message, is that the money that's being given to local authorities, the 3.6 billion, another 600 million, is not feeding through to providers. You indicated that 70% of the local authorities you deal with are not responding in terms of providing additional funding to cover these significant coronavirus costs. So I think cost is clearly a big theme. Testing was another theme, which you mentioned in terms of your inability to actually get testing for the vast majority of your residents, but actually more importantly, your staff. So I know that's a really key theme which we want to explore later, is staff who may be even asymptomatic, coming into services and infecting people. And the final one around liability, the two takeaways I've got is it's critical to have a paper trail, particularly because this is going to be looked at retrospectively. And I think also the mental health elements, particularly around employees even having, you know, PTSD, forming ethics committees, you mentioned that, but I think it's very important to have collective responsibility for some of the difficult decisions. And I think on that note, it's highly appropriate that we should be turning to Sarah Livingston, who's the General Counsel for Elysium Healthcare, who are one of the largest mental health providers in the country. So Sarah, I will turn over to you to introduce Elysium and also how you're approaching things.
Thanks very much, Henry. Good morning, everybody. So as Henry said, Elysium is a large provider of services across England and Wales. We provide services in the mental health, learning disability, children and young people, and neurology, and have a division for learning disability and autism. Our approach for us, we found that February and March, that the fear of the unknown, that feeling what you're waiting for the storm to come, you're battening down as many hatches as you possibly can, but wondering when the storm's going to come, how it's going to come, how long it's going to last for. And that led to a significant amount of anxiety from both the frontline workers and the support teams, whilst we try to see what was going to happen, predict it, plan as much as you can for the future when you don't know what you're planning for and what's going to happen next. April, I think, was particularly tough. Most people I've spoken to experienced the same high numbers of staff self-isolating. And again, similar to Mark, making sure that those people were protected, that they were able to isolate at home for 7 or 14 days on full pay. One of the hardest things for us was finding out things from the government at the same time as all of our teams. So sitting there watching the 5 o'clock broadcast to discover that you suddenly need to self-isolate for 14 days if anybody in your family has symptoms, which means the next day you receive 500 phone calls from staff, which you weren't prepared for, but perhaps your staff thought you should have been prepared for, but we didn't have the same level as notice as they expected. And I think that we believe that April was the start, with high numbers of sickness, starting to have reported cases in homes and in hospitals, and that was difficult as well. Now you look back and you realise actually that was the first peak, but at the time you didn't know that, and you were still running at 100 miles an hour, and we still don't know what second, third peaks look like. Lockdown we saw the benefit of, and we've seen large numbers of staff return and infection rates reduce. We are interested to see the impact on the eased lockdown, and we have services in England and Wales and are comparing between the two based on that. Our approach, very, very similar to community integrated care. We have a very formal and structured approach. Early on, we set up a steering committee, which was a formal committee of the operational board with all senior representatives on it. And over time, that's grown various subcommittees. So we have a committee that reviews the guidance and makes recommendations. We have infection control and cleaning, and chlorine tablets that feature quite heavily on there, a PPE and procurement committee, an ethics committee for similar reasons, to make sure that difficult decisions are taken in a considered fashion by a committee of people with documented decisions. We also have a staff wellbeing committee and have put quite considerable time and effort into ensuring our staff wellbeing. And also extra staff Q&A function so that staff can call or email to ask additional questions, which we found hugely helpful, because actually that's where we've realised that perhaps our guidance has been interpreted differently at different services, or wasn't as clear as we perhaps thought it was when we signed it off, but now it's with the frontline staff, we've seen some places that we can improve on it. The guidance has been difficult. The time that the guidance has come out, it's written, as Henry said, hospital guidance is written for the acute sector, and we're trying to interpret it for the mental health sector. Care home guidance is often written for the elderly care and doesn't take into account perhaps learning disability and autism or neurology. And so we've had to really concentrate on making sure that we've safely interpreted guidance, perhaps been a little bit more stringent than the guidance just to protect ourselves. I think May has seen more of a rhythm and more of this becoming, dare I say it, business as usual. We've now been able to upgrade some of our systems so that we're able to send out a weekly table to all registered managers. This is all the guidance that's changed this week. Make sure you've picked up on these things. We also have an assurance process with the quality managers who are going and virtually in most cases checking that the guidance has been interpreted correctly and the measures are in place. And that's been very useful, again, just to pick up areas where the guidance isn't getting through or has been interpreted differently to how we intended it. Medium term, as I said, I think we need to focus on the fact that this is probably going to be the way we're going to operate until, I would predict, the end of March at the earliest. This is going to be a tough winter. And now is the time really to resource up where possible. Similar to Mark, we can reduce the amount of time for onboarding. We are going to need extra staff, but also extra support staff, where people were collating daily sit reps for 7 days a week. That's sustainable in a crisis for 4 or 5 weeks. It's not sustainable for one person to work 7 days a week for 10 months. That person needs a team. The people reviewing and writing guidance, they're going to need breaks, they're going to need holiday. We need to get away from groupthink. So resources in those areas to make sure that everybody's covered. And then one of our standard agenda items, which is, don't forget, it's not always COVID, just to make sure that the other risks to the business are being picked up, and that we're not just all looking at one flashing light, wondering why that's flashing whilst the plane crashes. That's really, Henry, my experience.
No, look, Sarah, that's very, very helpful, and thank you for that. I think, again, just to sort of really pull a couple of themes out of what you said. One is around guidance. First, that it doesn't necessarily map over to your services because it's written for other people, but also it's changing all the time. So it's quite a dynamic situation. Secondly, around resources, which I thought was very interesting. And if we are in for a hard winter and we are going to have to staff up, people are working, as you said, very, very hard at the moment because there's the impetus of the pandemic where people do pull together and they do go the extra mile and work the extra hours, but that's not sustainable. So I saw that Elysium in particular has had a number of advertising campaigns as it looks to recruit additional staff. And you'll be using all the new onboarding remote techniques for that, I'm sure. And then the final one, which was around the non-COVID risks, because there's certainly a lot of collateral risks around this, just aside from the pandemic itself. And as someone who obviously provides mental health services, I would say that mental health component was a big one of them. But they're also they're the unknown unknowns, if that makes sense. Which will only come out over time. So I think that again is a very good segue into Ruth Winterbotham, who's a partner at DAC Beachcroft with a particular focus on claims and liability. Because I think as I sit here and I talk to directors and officers who are looking about their personal liability as directors of providers, and as I look at people who are looking at a whole range of different issues that we're facing. It'd be very interesting to hear from you, Ruth, how that's playing out in terms of what your clients are asking you and the advice that you're giving. So over to you, Ruth.
Thanks, Henry. Just those are the wrong slides, so those are Jill's slides. So if you can just put the other set of slides up. Just in advance of that, I'm just going to look at areas which might form the basis of claims, the type of claims that we might see, and then just to explore some steps that might be taken so that you can mitigate the level of risk to as low a level as possible. There's a lot of information on the slides. I'll only be able to get through some of that in the time we have available. But looking first of all, I think, as you say, we're right on the edge of a precipice, and my perception is that as we come out of the critical phase and with the continued uncertainty around the financial position and wait for the second wave of COVID, then it seems to be at the precise time at which you would expect the claims momentum to start to gather. Certainly, I'm aware of a number of companies that have been set up whose names would suggest that they are going to have a real focus on COVID-19 and have expertise in that area, and I expect that there will be a gathering momentum around that. So firstly, just looking at the areas where I think would be scrutinised in relation to the basis for claims. PPE will be front and central, as you would expect, but as well as availability issues, there will also be issues relating to the level of training and guidance given to staff, particularly where those members of staff are not familiar with using PPE. So having documented procedures around that, monitoring effectiveness of those procedures, and then responding to the guidance as it has changed, as we have seen over many different guises in a very short space of time. Other areas will be hand washing facilities, general cleaning policies in relation to reducing the risk of infection from contaminated surfaces. Social distancing is a particularly vexed question, very difficult in terms of the breadth of care services that are provided. Again, with that, the evidence of a policy, but putting that policy and your response to the guidance into perspective so that you can identify those issues that are preventing you from being fully compliant with government guidelines because of practical difficulties dealing with adults who are unable to maintain social distancing. This all needs to be documented where possible so that you can protect your position as much as you can. It's likely that as many as 5% of the general public are carrying the virus with no symptoms, and therefore preventing the virus coming onto your premises would appear impossible in all circumstances. But having good policies around health surveillance so that employees know exactly what they need to do regarding confirmation of having symptoms, self-isolating, etc., is also going to be important. And then you have what might be the knock-on effect of COVID, such as the effect of reduced staffing, reduced resources, so that manual handling policies are more difficult to effectively comply with. The time that it takes to identify needs and changes in care requirements and then document those, communicate those to other members of staff. One issue that we see a lot in assault cases is whether staffing ratios have been complied with. So documentation around that is going to be important. The increased number of agency staff means that unfamiliarity with procedures, with colleagues, with service users may all cause disruption, and that may well give rise to circumstances which give rise to claims. The overall management of what has been significant change over a very short period and the effective communication of that will necessarily be a focus, because that leads to deficiencies of documentation, and that is usually a breeding ground for claims. And then working in areas where employees are working in very challenging conditions. They may be working in unfamiliar areas. Overload of work may mean that it's more likely that errors will be caused. So that's employment liability. Looking at PL and MedMal, you're looking at very similar issues. I think there will be challenges by families in relation to coroners calling inquests where it's thought that human error may have contributed to the cause of death, where it's been certified. You have the same issues relating to resourcing. And I think the point that Sarah raised was being able to understand what you might be missing. So if staff are completely distracted by dealing with the issues arising from COVID, dealing with unfamiliar issues, are they taking their eye off the possible triggers that are evident in relation to behavioural change? Are they missing infection? Are they not being able to comply with the day job as they would normally do because of distraction, because of anxiety, because of other reasons? And is that likely to increase the risk of those other non-COVID related aspects to lead to further claims? Again, I think admission and triage procedures will be scrutinised, and that's another area where you need to be aware may well be a breeding ground for claims to follow. The claims, I think, will fall into three separate areas. I think you will see claims for employees having developed infection. Those are very difficult claims to prove legally. The lack of a formal diagnosis in many of the earlier cases due to lack of testing at that time will lead to difficulties in proof. And then there's the issue around causation. At the moment, there is a legal debate going on as to the appropriate tests to apply, where you have employees who will be working still living at home, travelling by public transport, going to the supermarket, being exposed to environmental sources of infection, it's going to be very difficult for them to prove that on balance the infection has been caused in occupational circumstances. However, in a health and social care environment, when COVID-19 is already present on site, it's easier than in a commercial environment where you might not have that aspect. So just be alive, and I think follow that that discussion as it develops. I think psychiatric injury is necessarily going to be an area where we'll see a significant amount of activity. The level of anxiety and circumstances in which staff are working, coupled with difficulties in relation to the availability of PPE, and the problems and difficulties with regard to social distancing, is likely to cause anxiety and distress, which, if that develops into a recognisable psychiatric condition, is likely to lead to a claim. You also have a number of senior staff making what are very difficult decisions on a regular basis, balancing a significant number of risk factors. And if you add into that mix the amount of change there has been over a period of time, the relentless nature of that decision making having to be made, and if you add to that taking them away from their support network of being around people with whom they can share those issues, so people working from home, potentially isolated and potentially not having the support network around them, means that, again, workplace stress related claims are likely to follow. And then the physical injuries from the manual handling, from the resourcing issues. Changes in routines, in adult social care in particular, may mean a significant level of disruption, which is then difficult to manage and may well lead to challenging behaviours that lead to an increase in assault type claims. So what can you do? Well, there are lots of things I think that I would be advocating now to protect your position as much as possible. Document everything. But in relation to documentation, not just the decision that's been reached, but also all the risk factors you're having to balance in order to reach that decision. Have the centrally produced guidance at the heart of those. But if there are difficulties in being able to comply with that, make sure that you record the background to your decision-making process. One of the hardest things to get across to a court and a judge in health and social care claims is reproducing the environment in which you operate and the difficulty of decision-making in that environment. So any way that you can produce that into your documentation, if you're keeping diaries, if you're doing a blog, make sure that that information is captured, because it will add a lot of colour and protection to the decision-making processes that you're going through. Nuts and bolts records need to be names of employees, especially where agency staff are being used, who was working on a particular shift and also who wasn't, because we will need to see that for evidential reasons. Dating things, making sure that people who are involved in decision-making processes are recorded, because they will be key witnesses ultimately, and the dating because you will need to cross-reference the timing of any decisions as against the guidance that was in place at the time, and given the evolution of that over a short period of time, that's going to be particularly difficult. Communication and constant engagement with staff. Mark gave some very good examples of how that works in progress and how supportive and protective that can be. The provision of a confidential advice line or access to support for employees is also highly protective in the arena of workplace stress. And then continually reassessing. I think someone had mentioned that one member of staff's full-time job is to just look at the changes in guidelines, see how that impacts upon you, see how you then need to go back to whether or not your risk assessments need to be reviewed. And one final point, and I would add that at this stage, although we're 2-3 months in, we're still a long way from where these claims may well be brought. And it's a lot easier now to try to go back to look at where you may feel there are vulnerabilities in your documentation, put those into context, try to add some colour to them, try to add some more detail where you think that might be missing, because to do that now at this stage is going to be far easier than when it may take 2 to 3 years, maybe even more, before statements are required in a litigated case.
Ruth, thank you very much indeed for that. I think that was an incredibly practical series of slides with some very, very good common sense advice on there. I think the takeaway I've had is definitely document, document, document. but also the other two, which was communicate and review and assess. And it seems to me there are two elements of this from a liability perspective. One is that actually causality is going to be a really difficult one to prove. And secondly, that there is going to be a significant time lag between what's happening now and any of this reaching the courts. But there are clearly some very sensible guidelines that you've given to providers in terms of how they can protect themselves and minimize that liability. So thank you for that. We're now going to turn to Jill. And Jill is a partner with more of a focus on the regulatory aspects, which will also be incredibly important in this, because the regulator is clearly one element of what providers are having to deal with every day, aside from their staff, their service users, local authorities, private funders. So Jill, I'm just going to make sure I get to your first slide, and I will hand over to you.
Thanks, Henry, and good morning, everybody. So Ruth talked about the future claims liability, but it's worth emphasising that if that wasn't bad enough, COVID also creates a much broader regulatory risk for health and social care providers. That's in the context of CQC scrutiny, what coroners might say in the future, possibly public inquiries, and certainly at least in the court of public opinion. And while you'll all be focused very much currently on keeping your patients, your residents and your staff safe, you'll also want to be sure in the future that your people, both clinical and senior management, aren't going to be pulled apart in the context of future retrospective scrutiny when this is looked back upon. And of course, for many of you, you also need to stay solvent, which is a challenge in itself. And as part of that, you need to be comfortable that none of the relevant regulators are going to deem you unsafe or not sufficiently well led to continue to provide the services that you now are. So just as a general note of caution, gently, the sense of false security or perhaps assumption that there might be some benefit of the doubt given for health and social care providers and professionals. We've heard from some coroners and some of the professional regulators that there will be some leeway, in which case great, but of course there are so many different regulators with different remits and different audiences. It's going to be very hard to predict and manage that. And the reality is, if your services aren't safe, at some stage you will have to answer questions about that and be ready to do so. I think from a regulatory perspective, as Ruth mentioned, it's just worth emphasising that when I think 6 months or 12 months or 18 months down the line, and what our inquest team, for example, will be managing, I'm far less worried about the COVID infection deaths that we'll be dealing with, and more about those ligatures or choking or falls, where the suggestion is that the staff response was negatively influenced by everything else that was going on. And Ruth talked about that in the context of the claims. And we're seeing already that the deviation from good practice on a temporary basis, because this is an emergency, through to unlawful practice and a lack of governance and systems is a really fine line. We've already seen, for example, a judicial review relating to whether mental health patients could have leave. And we had a reminder in the Court of Protection last week that just because we have COVID, providers can't ignore deprivation of liberty. And I think that brings us full circle with what Ruth said, because of course, to the extent that there's public scrutiny in other forum, that's also going to fuel claims. So moving on to the key health and social care inspectorate, the CQC, as you'll be aware, there aren't going to be, probably for some considerable period of time, planned inspections in the ordinary way, and therefore your relationship with your CQC team will be a combination of the emergency support framework, which is effectively a flexible conversation approach, combined with the reactive and follow-up inspections that will continue. So as you would expect, to the extent that CQC hear via whistleblowing or increased incident notifications that there are concerns at a service, they are still going to look at you, be that virtually or in person. And when they do that, they will be considering similar criteria as in the pre-COVID world. So you will still need to be in a position to make sure you can provide the assurances around issues such as safe staffing, risk management, and quality and safety. And those individual summary reports which are coming out of the new world of CQC monitoring and inspection are different. They're not going to be published in the same way, but you do need to be aware that they will still be shared with local authorities, with commissioners, And where necessary, CQC will still take regulatory action, so the assurances need to be in place. Rhys talked about some of the issues, for example, with PPE that you'd need to think about in the context of claims. Some of those will obviously be very relevant in terms of regulator scrutiny too, but from a slightly different angle. So whereas for the purposes of your claims, it will be a matter of what obligations you owed to an individual member of staff or resident and whether you've caused them damage. In the context of CQC and others looking at how you managed COVID-19, it's going to be about whether you're a safe, well-led service, whether the robust decision-making was there, and whether you had a well-supported workforce who knew how to keep people safe in very dangerous times. And some of those criteria which are on the slide there are similar to those Ruth referred to, but it's looking at it from a slightly different angle in terms of your overall organisational response. And then just finally thinking about mental health services specifically. Now, obviously this will be very close to the heart of the likes of Sarah, who manage the specialist providers, but I think it's really very important, much more broadly than that, because almost all of you will look after some of our most vulnerable citizens, not necessarily those with defined mental disorders, but those who lack capacity or are vulnerable for whatever reason. I was talking to one of our acute trust clients last week who educated me to the extent that approximately 30% of people coming through A&E lack capacity. Well, whether that's because they're unconscious, because they're drunk, or because they're elderly with dementia, it doesn't really matter. The implications for decision making around testing or isolation or anything else COVID related are obviously really significant. And then when you think about managing some of the challenges across the sector within that mental health region, then it's the same challenges: infection control, isolation, testing, PPE, but in additional complexity. So if we're talking about isolation, that's not easy in ITU, and we hear an awful lot about ITU, but it's, I would hazard to guess, even more difficult if you're running a very small learning disability residential unit with individuals who are used to going to the park and the shops and are not keen on the new restrictions, and they get very distressed when anything changes. Similarly with testing, it's hard for everybody, but if you've got a queue of enthusiastic patients, it's probably easier than if you've got a ward full of people who will at best refuse and at worst resist. And the legalities around how you manage that are really quite complicated. PPE, again, we've talked about throughout, and CPR has been a particular hot potato in terms of the various incarnations we've had of the guidance about what is and isn't required. But if you imagine dealing with a patient ligature on an inpatient mental health ward, and who should or shouldn't be wearing what sort of PPE, but the person needs cutting down and resuscitating immediately, then there isn't time to do anything other than an immediate response. So those staff need to be prepared well in advance. There's also some specific challenges for mental health services, which I won't go into in any detail now, but quite rightly so, there are very specific balances and checks around assessments and recording of signatures and records in the context of those who have their liberty infringed, either through the mental health or the mental capacity framework. And that's very difficult in a world where we're trying to do everything virtually and electronically. There are some workarounds, but they themselves will create challenges in the future when individuals have to prove what happened, control different versions of the same document, and justify any shortcuts. So just to conclude, it's stating the blindingly obvious, but it's important. The legal framework wasn't designed for a pandemic. So we spent a lot of time helping providers look at the complexities, for example, of how you deal with patients who don't want to be isolated. Can you use the implied powers of the Mental Health Act there? Can you use the Mental Capacity Act? Should you be using the new Schedule 21 power, which is designed for detaining and screening and assessing in this context? But you probably haven't heard of it because you'd need a public health officer to use that power. And anecdotally, it's not quite clear where you would find one of those. So we've helped an awful lot of providers work around that, but it is a workaround because the bottom line is the framework didn't anticipate and doesn't work in this context. So I think in the future, coming back to claims again, it won't just be claims which arise out of being infected, it will be claims which arise out of being deprived of your liberty or having your right to see your family interfered with or not being able to go out sufficiently often, or heaven forbid the Human Rights Act challenges which come as a result of those particular obligations. And on that cheerful note, I shall pass back to Henry.
Thank you very much, Jill. Again, some key themes from what you were talking about there. I think my takeaway was that providers should not assume that there will be any leeway in terms of the quality of the service that they're delivering. There isn't a pandemic pass here. That there is currently a lack of clarity about exactly how you respond in a number of services, just because it's a complex area. And to be fair, I think it's impossible to legislate or publish guidance for every single scenario. There's an element of common sense and practicality and frankly following some of the sort of the basic principles rather than designing everything to incredible detail. But the final thing is I would hope that the regulators will be pragmatic in the way that many other government departments have been in very exceptional circumstances, and that we won't, as a result, see things degenerate into too much litigation. This is not the United States. On that topic, I'm now going to turn over to Philip Dern. Philip is the healthcare practice lead at Marsh, which is, I believe, the largest healthcare broker in the world, but has a very significant healthcare practice. And I think a lot of the issues that we've heard about from Sarah and Mark and from Ruth and Jill are landing on his desk, with people asking about how they manage that liability and can they offset it in the broader market. So on that, I will hand over to you, Philip.
Thanks, Henry. Good morning, everybody. Just a very brief introduction to Marsh for those who don't know us. We're the world's largest risk and advisory and insurance broking firm. We employ roughly 75,000 people around the planet, with a turnover of roughly £14 billion. And we place around £1 billion worth of premiums for healthcare clients globally. We also run in excess of 100 captives for the healthcare world. And we've been supporting our considerable book of healthcare clients, which range from very large, well-known operators to the smaller operators through different parts of Marsh. We've been supporting these clients, right through the sort of 2.5 months of this crisis, and will continue to do so on a number of different levels. We've had a really good overview from Ruth and Jill around the legal and regulatory sort of background and where we're expecting to see the challenges. So I'm not going to sort of duplicate too much, and we've had an excellent overview from two of the major operators in the care and healthcare space in terms of the challenges that they've seen and some of the practicalities. So we're supporting our clients around the straightforward insurance broking, the advisory, the claims handling. We're also working with clients on crisis management, business impact forecasting, claims defensibility, and all of those things. So we've already seen some claims come in, some early stage claims. We've seen claims in the US and Canada, and if you look at the slide there, those are the three sort of key areas where we're expecting to see the claims. So the public liability cover, treatment risk and medical malpractice, employee liability cover, without any shadow of a doubt, around PPE, stress. And I think we haven't yet seen the impact of what the influx of those claims is going to look like. But as Ruth and Jill mentioned, it looks as if certain parts of the legal world are gearing up for this. So the insurance market, just to give you an overview, they've been reading the media the same as everybody else, and they look at the data that comes out from the Office of National Statistics and elsewhere, and they see all the stuff about PPE and infection control and agency staff and transmission and all of these different issues. And so what we've seen over the last few weeks, and bearing in mind, we only had the first sort of fatality in the UK, I think it was in early March. There have been 6 insurers that have in the last few weeks stopped writing new business for healthcare providers, and particularly for the care sector, in a relatively small marketplace, because there are some unique and key covers that need to apply in the healthcare world. Most of those are continuing to offer renewals, but they won't write new business. And there was one major healthcare provider that had already withdrawn from the UK market, nothing to do with COVID-19, which means that all of their business has to be replaced on what is in a diminishing market. Markets are becoming more volatile, they're becoming more challenging. I was on a call a couple of days ago with one of the larger insurers in the sector, where they effectively said, we're not writing any new business, we're looking for minimum of 50% pricing increases, and we're excluding pandemic and COVID-19 and infectious disease cover going forwards. So it's going to be a challenge, and we're advocating to our clients a number of different ways in which they can try to mitigate the impact of this, in which we can help them. But I don't want to, I don't want to paint a picture that it's going to be easy out there, because unfortunately it's not. So some of the areas in which, healthcare providers and the care sector can help itself. Claims defensibility, Ruth talked quite a lot about that. Obviously, the tests remain to be seen in terms of what the legal thresholds will be. I'm not going to duplicate on what she's already said, but audit trails are going to be crucial in terms of what you did, how you did it, why you did it. So make sure you've got everything that you can. As far as your renewals are concerned, so if you've got renewals that come up in the second half of this year and even into next year, start your renewal process with your broker much earlier than you normally do. Don't leave it until a month before renewal. That could cause you some serious challenges. One of the things that insurers are doing, they're going to be asking you lots of questions around infection control, PPE, how you're managing your agency staff, how you're managing the sort of transmission exposure. But they're also going to be looking far harder, I think, at the likes of CQC reports and looking to see where improvements are required and what you've done about them. So I think a fresh approach is probably going to be needed in terms of how you buy insurance. If there's any questions, obviously happy to take them offline. Specifically, I think trying to replicate what you've got for some of the larger operators, the schemes that are out there for the smaller operators, they may react to this slower. They tend to be looked at more ring fence. But if you could just go back to the previous slide quickly, Henry, if that's okay. I just want to just talk through a couple of bits. So I think in terms of how you approach your renewal process, start it early, take a blank sheet of paper, look at what your essentials are. Can you retain any more risk? How do you demonstrate your risk management capabilities, and what are you doing in terms of mitigation? Understand, talk to your broker around what good looks like to insurers. Talk to your backers and your investors, if you've got them, to see how what you're doing is aligned to their exit strategy. And get a really good sense of how your broker's positioned to help you and how they are helping you. And also think about what your plan B looks like. Thanks. If you can move on to the next slide. So other areas in which we're talking to businesses in a more sort of advisory perspective, we've got this rapidly evolving situation. There's no clear economic outcome of this. The Bank of England sort of gave relatively positive sort of messages last week. The Chancellor gave pretty gloomy messages yesterday. There's other areas that people need to think about in terms of supply chain management going forwards. How are you going to source your PPE? How are you going to source other consumables that are necessary? What is the resilience of the business? As Jill mentioned, solvency. How are you going to deal with your regulator? How are you going to update your risk register? in terms of, what does that look like going forwards. So we've seen in Canada a claim against a care provider, a class action, where the allegation was a pretty broad one and it was against the board of directors, and the allegation was failure to prepare for a pandemic. And they're actually pursuing the board of directors. So talking to your broker and understanding what your directors and officers policy covers is going to be really important, because there's no market consistency from an insurance perspective over that. And looking at how insurers are going to react, I mean, as I say, that they're going to, the market's contracted, pricing is going to go up. I don't think there's any doubt about that. Insurance markets are looking at billions of claims at the moment that are being submitted on a whole number of different types of area in relation to COVID-19, from business interruption to employees' liability, etc. It's not just the types of risks that would necessarily appear in the care sector. They have to maintain solvency margins. They're not making any money from investment returns. So, insurers are going to obviously catch a cold as far as this is concerned, and quite a considerable one. And the background was that insurance pricing had been starting to increase globally for some time. So I think probably we're going to be entering the most difficult insurance buying conditions that we've seen for quite some time. And so I think how you sort of approach this is going to be critical. Analytics, data, really important in terms of being able to access a broker that's got that analytics capability, has got the benchmarking capability, and the ability to work with the markets to get you the best results. If you move on to the next one, that'd be really helpful. That's a bit busy, but I think some of the things that we're already starting to see and think about. So obviously at the front line, the staff that are providing the care on a day-to-day basis are doing pretty much what they're doing. But what's the new normal going to look like as we start to move into the next phase of this? And so, how are you going to start to return your office staff? When do you return your office staff? What sort of measures do you need to be taking? How can you try to reconfigure your services in terms of some of the things that have been talked about? Are there ways of doing things differently? Will you, how long will you need to, be spending money on increased levels of PPE? And will some of your services potentially become deemed to be unsafe because of the way they're configured? So I think we can work with clients and help clients, and we are doing all the time in a whole range of industries, including the healthcare industry, in terms of how they can approach these sorts of things. Unfortunately, the health and social care, the care sector, social care, whether it's special needs or elderly, doesn't matter which part. The private hospitals were obviously given the benefit of NHS indemnity in respect of the NHS patients that came into the private hospitals. The actual utilisation of those beds was relatively low. It wasn't quite as low as the Nightingale hospitals, but unfortunately the care sector doesn't have the benefit of that state indemnity to rely on. And so it's going to be, your insurers that are going to have to deal with this on your behalf, unfortunately. If you could move on to the next one, Henry. Thanks. So, laying the foundations for the future, I think, talk to your communities, your suppliers, your staff, your commissioners, how you're going to approach the risk. Good communication all the way through. Mark and Sarah talked about it right at the beginning. Maintaining those really strong relationships and understanding and reacting is going to be really important. Modeling the scenarios to understand the impact on your business going forwards, I think, is going to be really, really important. And and maintain as much dialogue as you can with your brokers or other advisors around what insurance cover you really need, what's the cost going to look like, and how you're going to manage the claims. I think one important thing to mention on the claims aspect, anybody that's got full medical malpractice cover or any claims made wordings, I'm not going to go into technicalities on insurance this morning, but you need to be ensuring that you notify those claims within the policy year in which they occurred. Really important point. If you've got an insurer that's not going to provide you with the cover going forwards, if you haven't notified it, you could be leaving your balance sheet exposed. So you need to get some advice on that as well. Really sorry, it's not a more positive message in what are very challenging times, but unfortunately that's the reality that we're facing.
Philip, thank you very much indeed for that. I think 3 takeaways from me. One is cost. Premiums could go up 50%. The second is cover. Already we're seeing people excluding pandemic cover. And the third is start talking to your brokers early, because this is a moving feast. And I think the market is we're trying to work out where risk and reward sits. So we've got 10 minutes left. And I'm just going to put up where we are on the poll. The biggest one is what risks I am missing, i.e. what the unknown unknowns, with liability for employees and for service users actually tying at around 25%. And actually insurance cover right down there at 6%. Probably not good news for Philip, but maybe his speech has given people cause to focus on that a little bit more. I'm now going to switch to the Q&A, and the Q&A is very much a case for where people want to upvote questions that are relevant. I'm going to kick off actually with the one around ethics, because both Mark and Sarah mentioned that they have ethics committees. And I think what would be very helpful for people is just to understand what sort of topics that ethics committee is actually discussing and what sort of difficult choices they're having to deal with. So maybe Mark, if I start with you, and we've only got 10 minutes, so I have to keep the answers relatively short, but I think it'd be really interesting for people to hear your thoughts.
Yeah, thanks, Henry, and thanks, Susan, for the question. Obviously, the ethics committee is trying to create a shared responsibility, and just to play devil's advocate at some of the thorny questions we have, I think it was triggered around our decision to have a block on allowing loved ones to visit in an end-of-life situation. So obviously you had the desperately sad and difficult situation where you had people that were under palliative care. You knew that they might have 6-12 hours left to live, and people were saying their goodbyes by iPads or looking through windows, which at a human level is completely unsatisfactory. It obviously isn't right from a human rights point of view, but is probably right from a kind of greater good for the human rights point of view. When we had Matt Hancock stand up and unilaterally change the rules and say, no, everybody should have the right to say goodbye, we felt that we had to really look at circumstances that this wasn't just necessarily in a nursing home environment where you might have ability to isolate and full use of PPE and appropriate areas for isolation, but in supported living where you might have 3 people with severe autism being supported by 3 care workers. If you have an end-of-life situation in effectively a semi-detached house, is it safe for the other residents and staff if you do have people visiting in those circumstances? So that was one area. You had issues like furloughed staff wanting to return and saying, notwithstanding the guidance, they want to come back and work on the front line. You obviously had the whole area of PPE, and in some supported living areas, we felt that the guidance was still too low, and we actually upgraded on the Public Health England recommendations. How do we support families in bereavement? The transport issue in terms of getting care workers safely to work and back. And the issue I think that was mentioned, if you've got the right to go out to the park and meet another adult and have 2 meter safe distancing, Well, if you're in a care environment where you've got somebody that's on 2-to-1 care, then if you go to the park, you start off with 4 people, and is that satisfactory? And if everybody in a home does that, you know, you could be filling the park. So these are the sorts of issues that have gone to the ethics committee.
Sarah, I guess on your side, you're in a slightly different market, but are they similar themes for you as well?
Very similar, actually. I would just echo what Mark said, and some of the difficult decisions that have been made, but nothing different to what Mark said.
Very good. The other questions are very much around confusing advice and information from Public Health England and people's liability if they're trying to follow this advice, but it's a moving target. And I guess, Ruth, you're probably best placed to answer that one. And if you're able to address the next one, which is whether you think that sort of PPI mass claims culture might develop post-COVID, that would also be helpful.
So just the first one first, it goes back to what I said about effectively showing your working around your decision-making process. So if you have decided to do something in a particular way on the basis of the government advice, record why you took that decision at the time that you did and try to date it. Because of the rapid change in advice that's been given, your judgment and the steps you took will be judged against that, but only on the grounds of reasonableness. So as an employer, your duty is to take the reasonable steps to protect employees, subject to what is reasonably practicable. And if the guidance has been so confusing that it's impossible for you to follow that or to derive a clear line as to what you should be doing, then that will be evidence that's going to be very important in terms of protecting your position. So the direct question, are you potentially liable? Yes, it can't be ruled out, but there's an awful lot more information that you need to put around that decision-making process to protect you and to explain why you came to that decision. This is some of, as I was saying, some of the colour that we need to have added in to the evidence so that we can use that in the right way.
Thank you.
Sorry,
Ruth, we're just conscious of time. 30 seconds.
And the other issue, yes, can insurers, is there likely to be some sort of claims culture? Yes, it's possible. I think collaboration amongst the industries, particularly amongst insurers and those advising the insurers to make sure that there's consistency of approach is absolutely vital to guard against that. We don't know yet if there's going to be any government intervention in terms of a tariff or a protocol. That's possible, depending on the scale of the problem.
So final question to Jill, and this is a difficult balancing act. Duty of care to your employees versus duty of care to your patients and service users. How do you balance that?
Yeah. Well, obviously, ultimately, that is a circle that can't be squared. But I think in terms of limiting risk, it's a matter of making sure that your senior management team or your board, not just once, but on a regular basis, are taking into account all the guidance that is available and have made a decision and established on what basis that was made. And currently, that all of the staff within the organisation are aware of it and appreciate how it works in practice. So, for example, the PHA guidance has changed again now, but one supporter that we worked with effectively made a board decision that they would carry the employee risk because they preferred that to carrying the patient who, in the absence of an immediate ligature response, would be dead, and there would then be the inquest and everything which flowed from that. That's not a right decision or a wrong decision, but they ensured that the board level scrutiny of it was clear and transparent, and in the event that we have to defend it in the future, the documentation is there to be able to do that.
So look, there are a lot of nutty questions here which require far more time to give proper responses to, but nonetheless has been very, very interesting to actually touch on some of the key topics. I think we're now out of time, so it just remains for me to thank our partners, so DAC Beachcroft and Marsh. Thank you very much indeed. I think you've both come at it from a slightly different angle, which has been really complimentary today, actually, and some very practical advice, which is always welcome. Thank you also to Care Markets and Healthcare Markets, or the journals that cover this. LaingBuisson has a coronavirus toolkit. And if you go on there, we have links to content from both DAC and Marsh, which you can look up and give you more information. And then finally, our two charities Turn to Us and the Care Workers Charity, who are both helping people out there who are suffering as a result of coronavirus. So the webinar and the slides will be available very, very shortly. You can go to LaingBuissonEvents.com and you can download them. You can also make a donation to turn to us if you choose to, given this is a free webinar. All it remains for me to say is thank you to everybody who's attended, to the panelists, and we look forward to seeing you in due course for our next webinars. We've got one coming up on dental on the 4th of June, and then rights and regulation on the 11th of June. So again, goodbye and thank you.